Thank you for coming, and I think this is meant to be an educational and hopefully interactive session, and I'd like to thank Fujifilm for inviting me to speak to you today. So as I said, we're going to talk about the Doppler in normal heart, but I will introduce some abnormalities as well. So initially I'm going to talk about main Doppler modalities, very basics, and the Doppler in the normal heart as I go through the different modalities. And then I will finish off with a few examples of congenital heart disease, which I think makes it more interesting. Also, I think you've just seen here transition from black and white image to color. Color can add a lot of information, and although that's not part of cardiac screening from the ISUOG guidelines, a new revised version will strongly recommend the use of color. So I think to use that, we need to know how to use and how to interpret the information. So I'm going to start initially by highlighting that cardiac Doppler is different from the obstetric Doppler because the velocities are in general higher. So the cardiac velocities are usually around the mid-trimester, around 50 to 70 centimeters per second, but we still use lower velocity like the obstetric presets, which is around 20-25 centimeter. So color flow will give you information on direction. It is qualitative information. You don't measure the precise velocity and is angle dependent, at least for the conventional color. So this is very basics, but sometimes surprises me that some people who are just starting their training don't actually appreciate this is a color code and it can be changed. So red, anything that goes towards the transducer, and blue, anything that goes away from the transducer or the observer where your hand is. So more considerations about this. Velocity range are highlighted here because it is the main difference from the obstetric scanning. So sometimes people move from obstetric scanning to cardiac to heart without changing the velocities and give up before adjusting the settings. But everything else is important. Again, the color box size, which should be just concentrate on the area of interest, and I'll come back to the transducer frequency. Filter we don't usually change very much. So velocity range, it will determine the scale that you put on use the color will determine the velocity you're going to be mapping. So you need to choose the velocity very carefully, and I'll try and show you this on the image to avoid aliasing. Sometimes you do want to create aliasing to facilitate sampling the information you want in terms of absolute velocities. So these are two very simple still images showing that if you use a velocity around 70 for the intracardiac structures in mid-gestation, 20-24 weeks, you should get a smooth color called a laminar flow. So the velocity that you display is dependent on that scale, and this is usually in centimeters per second. So in here, for example, it doesn't give a lot of information about the heart, but because you're concentrating on pulmonary veins, and we'll come back to that. So higher velocities for intracardiac structures and lower velocity for the systemic and pulmonary veins, so depending on what you want to see. So it's also important to highlight that we can get aliasing in the normal circulation even if we are using those velocities, and the highest velocity in the venous circulation is that of the ductus venosus, which is around 50 centimeters per second if you are well aligned with the flow. So here we normally set the velocity. If you want to identify the ductus venosus, you set the velocity around 20-25 centimeters, depending on the gestational age, and you can see that you start with a very smooth color, laminar flow through the umbilical vein, and then you get that point. So you do want to highlight the aliasing to be able to sample the ductus venosus properly. So highest velocity on the venous circulation, and on the other side, the ductus arteriosus is the highest velocity on the arterial circulation, and therefore we can obtain aliasing in the normal heart, like in this example here. So nice, smooth color through the ductal artery, the main pulmonary artery. The actual duct has quite a lot of aliasing on a velocity that's approximately 60 centimeters per second. So this doesn't mean there is an abnormality. It just tells the velocity is higher. And the correct thing to do is to then do a post-wave sample of that and to actually measure the velocity and look at the post-wave Doppler signal. So just be aware of those information. So transducer frequency is something that in practice, my experience is most people don't appreciate that. It's very important. You don't just adjust the velocity and the other parameters we already discussed, but the frequency of the transducer. I don't mean changing your transducer probe. You change that for your 2D image, but once you choose your transducer, either low frequency or high frequency for the imaging, when you set into the color mode, you can still adjust the frequency band within the same transducer. And this is very important because the higher you choose the band of the frequency of the transducer for the color setting, the higher sensitivity. So if you have a slim patient, lower gestational age, and you're not looking high velocities, choose the high frequency band within the transducer that you're using. On the other side, if you're using, if you find stenosis or if the velocities are higher, or sometimes if you have a longer depth and you're not getting color, lower the band of the transducer to a lower frequency and you get a stronger signal, and you'll be able also to measure higher velocities. So this is something that needs to be changed quite often. So frequency of the transducer, velocity and gain are the main things. We'll demonstrate that. So also in terms of color, there's so many different modalities now. There's power Doppler that has been around for a long time. There's the high sensitivity, the E-flow from the Fuji system. And more than that now, we have this 3D appearance of the color, which I think when you start using that, you have to get used to that. But after you get used, it can add information. On the Fuji system, when you switch on the glossy effect of these colors, which you can put on the conventional colors showing here, you can see nicely a sweep from the 4-chamber to the vessels without color. That's with the conventional color, and this is with bidirectional power Doppler, which can give more defined information. We lose the velocity scale, so you need to come off that system, the glossy, to be able to read the velocities. So, but as you're doing it live, you know what kind of velocities you have set the system for. So this can be very useful, and they have different information. The power Doppler is less angle dependent, so, and it's more sensitive for small vessels. So you just need to use on whatever system you're using to get used to the different modalities that are available on your system. So if we start from the abdomen, because really starting looking at the fetal circulation, we should start looking from the ductus venosus. And I've shown this already here, the umbilical vein, the ductus venosus. And as we slowly sweep towards the abdomen, you can see towards the chest, you can see that ductus venosus start to join here with the hepatic veins and ends up around the inferior vena cava. So if we move a little bit higher on the same velocity scale, which we're looking at the ductus venosus, you see that it's very difficult to interpret the information on the vessels. You get a lot of aliasing because that velocity is not what you should be using to look at the arterial velocities, but it is the same velocity for looking at the pulmonary veins, and I'll show you that separately on the next slide. So you can see how you can see the veins on a low scale. So you can do that sweep from the ductus venosus to the abdomen on a low scale, and you'll be looking at pulmonary veins, or you can increase your velocity and start looking at the intracardiac anatomy, depending on the fetal position as well. So for me, it's very important that when you look at pulmonary veins, that you do a dual display, or you show both the 2D and the color, because in this one we can see very clearly where the atrial septum is, so we know the pulmonary veins are draining into the left atrium where they should go. But sometimes the image is not so clear, or the angulation is not so good, you may not see the atrial septum, and then just using the color can sometimes cause false impression that the veins are going into the left atrium, and you may have an abnormality of pulmonary venous return. So I think I would encourage using a dual display if you're looking at pulmonary veins specifically. So on a higher scale, which is what you should be doing if you're looking at the main vessels and the intracardiac flow through the tricuspid and mitral valves, you get a laminar flow. And you can see here in this example that using 62, you can also see very briefly a little bit of aliasing there, which is telling you there is a bit of tricuspid regurgitation, which in this case is kind of very physiological. Now, there is no increase in the cavities, but you can just see that very briefly. And if you find it difficult to see those things on a live scanning, you just freeze your image. Can't find it here now. There we are, just very briefly there. I think the light is a bit too bright, so I'll play it. If you concentrate on here, you see there is going to be a little flash of tricuspid regurgitation, which is the aliasing across the tricuspid valve, but it's smooth color across the great vessels, and right at the end we see the subclavian arteries as well. So in here we're not seeing color in the arterial duct. Correction, we are seeing on the duct, we're not seeing color on the transverse arch because this is at 90 degrees to the color, to the flow. So we're not seeing here either red or blue because we are at the wrong angulation to pick up the color. Sometimes we can see blue coming through the ductal arch and red going to the aortic arch, so different colors but the same direction, the correct direction. So lots of nuances that you can get with the color, conventional color. So this is an example of power Doppler and using a glossy appearance. I think the power complements, doesn't substitute the usual conventional color, and it's very good to look at the interventricular septum, particularly if you are in a good position. Sometimes with the spine up, it adds a lot of information. So this highlights, not only highlights the flow, but also in patients that have very high BMI, that sometimes you have a noisy image. If you put color on that particular Doppler, power Doppler, you can eliminate any noise that you have inside the cavity, so you maximize visualization of the 2D structures. And sometimes using color, again, can help you understand the anatomy. Like in this case, I've just labeled here the descending aorta, and it's a very short clip. And you can see here labeled the left ventricle, but you're not seeing it anymore, the right ventricle here, and the pulmonary artery. So if you compare the two, you can see here the left ventricle, the blue flow coming through towards the left ventricular outflow tract. You see the right ventricle with the red flow going, and that's your crossover here. So it's very difficult to show that and that same image. So the color tends to sample a little bit more than you're sampling with the 2D image. So you can get additional information that sometimes can be very helpful, particularly if the baby is not in the perfect position and if there is a high BMI or other factors that might affect the quality of the picture. And you can see here that the pulmonary artery comes here and it divides into the branch PAs, the left and the right. And then eventually, if you go a little bit higher, you can see the whole arterial duct. So it can be very, very useful and complementary. And this is something that I introduced some time ago just by chance, trying to optimize the gain between the 2D and the gain that you use for the color. And if you start with an image that you have the 2D and the color, so you can give priority to color or 2D. If you put too much gain on the 2D, you lose the information on the color. So on the other hand, if you decrease the 2D gain, you can get almost like a 3D appearance just on a normal system. So again, very useful if you have high BMI patients, sometimes difficult to see the aortic arch. And we've got a couple of small short publications on use of these, which I called just flow, because you can just see the like an angiogram in the child. Very easy to do as well. So moving briefly to spectral Doppler. Again, difference from the obstetric Doppler. The PI is important for the ductus venosus, but for the other velocities, we are interested in the actual velocities rather than PI. So it's important that we keep an angle of about 20 to 30 degrees to be able to read the correct velocity. If we have 90 degrees, we are underestimating the velocities. So we should always try and manipulate the baby to obtain the best angulation to read the velocities accurately. Again, the same applies here, and lots of the time people forget that you can do the same principles for the color, which is to adjust the frequency band of the transducer that you're using. You can go for high, medium, low frequency, and then lower frequency within the same transducer, within the same exam, you will be able to read higher velocities. So sometimes the signal is there and you can't read, so lower your velocity, or if there's a big depth, big baby's a long way, polyhydramnios or high BMI, so you can optimize a low frequency for the general habitus of the woman, but if you, within the pulse wave, change the frequency, you're going to get better signal. So again, higher frequency, more sensitivity, but lower frequency, you'll be able to read higher velocities. And this is probably not not so much of a problem nowadays, but I still encounter that. There's something called duplex and triplex that you should really avoid, and this is really exaggerating the problem. So if you got your sample volume in the correct place and you press the wrong button on your machine, and you can see that the signal looks awful, that's because the machine is trying to do a 2D that's live and the pulse wave at the same time. Worse than that, when you do triplex, so you have color, you have 2D, and you have the pulse wave, so the signal is very difficult to, so really there is a button which usually called an update, but sometimes it's confused, it's not very clear. So if you use, again, more or less correct angle, you can see the signals much more clean and much more informative. So that was the mitral valve, tricuspid valve. This is the mitral valve. Again, good angulation. And then is again using the gain, trying to get a clean envelope rather than too much gain when it's too bright. So this is much more, it's more beautiful to look at, and it's more accurate, because if you put too much gain, you're going to get higher velocities that you don't want to get. So again, angulation here. From that position, you can get your mitral, tricuspid, and your aortic velocity. So you're going to read the highest velocity, and also the sound is very important, which we can't reproduce here on the slides, but on the live session we can. So again, pulmonary valve in that particular position, it was not a good angle, had to go more or less sagittal to get your pulmonary. So very important to align your pulse wave with the flow direction. So you can see the waveforms for the arterial vessels. Now, one thing that I use very much is pulse wave in the pulmonary vein and artery simultaneously, because this for me is a good way of looking at the rhythm very quickly. You can identify ectopics and things like that, which can be difficult if you're using M mode across the four-chamber view, particularly if the four-chamber view is not very clear. So this is usually, most of the time, almost 100%, a very useful way of looking at the rhythm, this being atrial systole and this being ventricular systole. So you can see synchrony. You can also measure AV interval if you're investigating patients that have anti-rho, anti-la. There are other methods, but you can do on this as well. So it's usually around 20-24 weeks. The interval is mean around 120, and 3 standard deviation goes up to about 145 milliseconds. And I think I don't need to tell you about the ductal stenosis. You probably do that very often on your growth restriction babies. And so I think that covers more or less briefly the use of color and pulse wave and technical aspects in the normal heart. And I think I'd like to show you a few examples just to illustrate how it can be useful. It's not just in the normal heart. Maybe if you see an abnormality, you're not going to try and add more information, but some of you might. You may not have access immediately to a cardiologist that can give you the information. So let's start with a case here of critical pulmonary stenosis. So if you look at that four-chamber, maybe some of you would pass that four-chamber as normal. Maybe some of you would comment on the four-chamber. I think there is hypertrophy, if you haven't noticed that. So label the chambers, yeah. The contractility here is not quite the same as the left ventricle. You see how it changes. The right ventricle doesn't change very much. So those are subtle information that if you miss that on the 2D imaging, and if you put color on that, same baby, velocity of 73 for a 21-week fetus. So that's a good velocity. Then you see there is some tricuspid regurgitation at the beginning. When you come to the vessels, there's a lot of aliasing, which we should not be getting in the pulmonary artery because we are on a proper velocity. So this tells us, one, there is tricuspid regurgitation, two, there is a lot of aliasing in the pulmonary artery. What does it mean? That velocity across the pulmonary artery is higher than the velocity set on your scale. So this is the same baby. I've changed the scale because I'm getting so much aliasing. I'm trying to read, to clean the signal. So now we are almost twice as much as we were before, 146, and you still see lots of aliasing across the pulmonary valve, which means that velocity is much higher than 146, which is very high, which goes along with the pulmonary stenosis. In addition, you see here the pulmonary valve is very thick. You don't see it opening and closing, and the main pulmonary artery is dilated. So this is a case of critical pulmonary stenosis very early in the pregnancy. So very informative, but providing you use the correct scale. So in this case, we try to then measure the velocity because the color just tells us is higher than 146. And in here is in this case, I've used a continuous wave. So that's not available in all the obstetric systems. So if you use a pulse wave and the velocity is high, then you're going to use, what you're going to do is to lower the frequency of your transducer to be able to read the highest possible velocities. But because I had continuous wave, so this is the velocity of 330 centimeters per second as opposed to a normal of around 60 or 70. So it's very high velocity. You can calculate the gradient across the valve, and the formula is the modified Bernoulli equation, which is 4 times the square of the velocity. So in here at 3.3, and you do that in meters per second, so it will be 3.3 times 3.3 times 4, which gives a gradient of 44 across the pulmonary valve. And in here is the Doppler signal across the tricuspid regurgitation. You can see it's a good angulation, and this is reading a little bit higher, giving a gradient of 55. Probably because this pulse wave through the pulmonary valve, the angle is less than the angle here is less optimal than the angle for the tricuspid valve. So we are reading higher velocities here. So the gradient is probably higher than the 44 that we calculated. Now, this is a different case, case 2, very briefly. It's a case of hypoplastic left heart syndrome, already at 33 weeks of gestation. And you can see here the right atrium is labeled, the left atrium is small. There is no mitral valve, there is a tricuspid valve, this is the right ventricle. So you might or might not have noticed there's a bit of dilatation here. So those details are all important. When you put the color, you notice that it's very important if you have a case of hypoplastic left heart syndrome to see if there is regurgitation through the tricuspid valve, because these are all information that will help risk stratify for postoperative management. So if here we can see a bit of tricuspid regurgitation on a velocity that is 57. If we carry on the same velocity, moving from a 4-chamber to the 3-vessel view, we can see that there's a lot of aliasing in the pulmonary. She's 33 weeks, so maybe we're using a lower velocity, but this is a lot of aliasing here, and I think I'll change it subsequently. There is also some flow coming here, which maybe you're not able to appreciate on a 2D image alone, apart from having a very big superior vena cava. The aorta cannot be seen here because it's hypoplastic left heart, it's very small. So there's a higher velocity in 2 points here. So if we change the scale now to 84, you can see that the flow through the pulmonary is laminar. We still have some aliasing across the arterial duct. Here it's more laminar as it enters the superior vena cava, but we still have some aliasing. So in this case, if we do a pulse wave, now it changed the velocity to 100. Remember, in the vein, we shouldn't be getting that velocity, and this means there is obstruction. There's something getting there that is obstructed. So this again makes the case a higher risk for any postoperative surgical intervention. And this, I'm just going to go back to our 4-chamber view here with that area behind here close to the left atrium, and if we use the color, you can see that flow is coming this way, and I just made a composite here, and as you go up in the mediastinum, that flow comes towards the right side, and eventually it comes here and it joins the superior vena cava. So this is a case where the atrial septum was quite restrictive. There is no mitral valve, so the blood had found its way going up into a vein and draining into the superior vena cava. So these are complicating factors of hypoplastic left heart. So it may not be what you do every day. For you, it's important to identify there is an abnormality, but there's a lot of extra information that when you do a detailed cardiac scan, we have to use all of these facilities to be able to inform the family about the risks for that particular baby. And I think I'm just going to have one more, which is an abnormality that's quite common, coarctation of the aorta. This is an image of 35 weeks, and I think it's very important to look at the aortic arch if you're suspecting coarctation, rather than just suspecting that based on disproportion between the vessels. So in here we have a still image where I labeled the descending aorta. This is the distal part of the arterial duct. This is the aortic arch with its branches, and this is the insertion of the arch into the descending aorta, which is an area of coarctation. And you can see here the two vessels are very close together. So the aorta is smaller, and when you see a big one, that is not the aorta, which is the message on the next scan. So it can be misleading if you look at these and you think that this is the aorta. This is not the aortic arch. The aortic arch is separate, and you can see how the color helps separating that. But you have to have everything optimized, a narrow sector. You put a color box on the area that you want to see. I hope that you can appreciate that without me slowing it down, but if not, so this is not the aorta. This is the ductal arch that is very close to that. That is the aortic arch, which is smaller, and then you can see as I play, there's a little bit of flow persistence here, so we should sample that using pulsed wave. The baby needs to be quiet to do that because it's such a small area. And then you can see this is something that a lot of people are starting to explore, this persistence of flow as one of the many markers to help diagnose coarctation of the aorta, which is quite a tricky lesion. But I think the main message here is don't think that always that you see the aorta, that's the aorta, particularly if you are transitioning between the aortic arch and the ductal arch. So that's very briefly, and I hope that that's giving you food for thought for how to use your Doppler properly. It can give a lot of information, but if you use it in the wrong way, you don't get additional information. Thank you very much for being here. Thank you.
Coarctation.
Yes.
Can you please repeat about the persistent flow, because the diastolic flow?
So I think if you are scanning, and if you have your eyes and if you look at a lot of the aortic arch, you're going to see some flow persistence. I mean, people have looked at this is the isthmo area. People have looked at that because of Professor Fullholm many years ago talk about the isthmus as being an important part, particularly in IUGR. So you can have reversal flow through the isthmus because you have vasodilatation in the brain. So it's an area that there are quite a few papers there talking about the isthmus flow. So normally there is diastolic flow in the isthmus. The thing is how to quantify it. There is one paper looking at how much flow the VTI here going in diastole and going systole, doing a ratio. So it's not 100%, but it's one more way of trying to add the pieces to be more accurate with the diagnosis of coarctation, because there are quite a lot of false positives and false negatives. So if I play this here, if you look there, you can see that if you there is a point when you just see flow in diastole, and we are looking to that into more details to try and quantify that signal. At the moment it's more subjective. There is persistence, so sometimes you have very high velocities, sometimes it's very low, but as always is the one in between. So we need to try and make more measurements to try and find the specificity, sensitivity, that kind of thing. Yeah, but it's one more piece of the puzzle to try and improve the diagnosis of coarctation. Yeah, but for me, you know, this area here, with that angulation of the aortic arch, plus this flow, plus everything else you see, and this baby did have coarctation. Yeah.
Why did it cause this persistent diastolic flow? What does it cause from?
I think it's just because it's narrow, and then you know, flow is trying to get through. Yeah. Postnatal, you see a lot of that. It's not so much in the isthmus. You do see in the isthmus as well. Postnatal, you see that beyond the point of coarctation. Yeah. Many years ago, I published a paper which was looking at the flow in the descending aorta. If you look up my name, continuous waving coarctation, you'll find a paper that is too old. But we quantify that in the child, measuring the lots of things, time to peak diastolic velocity, time to sit. Have a look. It's free on the internet, the paper. Yeah.